Hello and welcome. I am Anthony Lembo. On behalf of the CME Outfitters and my colleagues, William Che and Douglas Drossman, I would like to welcome you and thank you for joining us for today's educational activity entitled Beyond the Old Paradigms, Novel Approaches to the Treatment of Chronic Idiopathic Constipation. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Our goal of today's activity is to help you safely and effectively improve the lives of your patients with CIC. Today's CME activity is also eligible for ABIM mock points. So make sure you engage in today's event, answer polling questions. After completing today's program, be sure to provide your ABIM number and birth date in the evaluation. CME Outfitters will submit your mock points. Again, I am Dr. Anthony Lembo. I'm a professor of medicine at Harvard Medical School and director of the GI Motility Lab at the Beth Israel Deaconess Medical Center. Let me introduce our esteemed faculty joining me today. First, let me welcome Dr. William Che. Dr. Che is the Timothy T. Nostrand Collegiate Professor of Gastroenterology and Nutrition Sciences at the University of Michigan in Ann Arbor. Welcome, Bill.
Thanks, Tony.
Let me also introduce Dr. Douglas Drossman. Dr. Drossman is the president of the Drossman Center for the Education and Practice of Biopsychosocial Care, president emeritus and COO of the Rome Foundation. He's also professor emeritus of medicine and psychiatry at UNC School of Medicine in Chapel Hill. Welcome, Doug.
Thanks for having me.
All right, let's start in on our program. Our first learning objective is to review the epidemiology and diagnosis of CIC. Before we start the discussion, I would like to learn more about your practice. You see a question on your screen, and you can choose your responses now. Doug and Bill, is this surprising to you? I know we have kind of a specialty practice in a tertiary care centers, but what do you guys think of this? Is this surprising, or does this represent the general population of CIC?
I can't see the results actually, but I'm hoping nobody's in that 76 to 100% category. If so, we got to make sure we invite them to be faculty on this program next time.
Well, I'm seeing 2/3 are at 21 to 25%, which is pretty reasonable for the prevalence of the population. And this is maybe primarily a primary care audience. So that would seem reasonable to me.
Yeah, that seems pretty reasonable as well. And some people are receiving even higher percentages of patients. All right, let's start with a case that we'll be referring to throughout the program. Doug, this is one of your patients. Do you want to walk us through it?
Sure. This is a 45-year-old woman referred by a primary care physician, and she had a history of relatively normal bowel movements 2 to 3 times a week, had a hysterectomy about 5 years earlier, and since then her bowel pattern changed to bowel movements once a week with associated symptoms of bloating, moderate abdominal discomfort, and passage of hard, small stools associated with some straining and a feeling of incomplete evacuation. She also noted that if she put pressure on a perineum, sometimes it would allow for easier passage of stool during a bowel movement. She was fearful of getting out of the house, not sure she could always find a restroom. She felt no one really understood what she's going through, and she's anxious that things will get worse as she ages. Treat this, she exercises often and eats a high fiber diet. She had a colonoscopy a year ago because symptoms became more severe, but the findings were normal. Physical exam was normal, except for the rectal exam, which showed incomplete relaxation upon simulating defecation and a small anterior rectocele. She then went on to have an anorectal motility study, which showed pelvic floor dyssynergia, and we'll talk more about that later. And she had a defecating proctogram that showed a small 2-centimeter rectocele, essentially like the rectal exam, but with normal evacuation of contrast.
Great, thanks, Doug. Doug, do you want to walk us through the data on the burden of CIC and how it affects our patients?
Well, it's very common. As you can see, it can affect 1 in 7 people. 35 million US adults have been reported. 7 in 10 people experience these symptoms for over 2 years. It does tend to affect women more than men, 17 versus 9% in one study. It's the 4th most common GI symptom, prompting clinic visits amounting to over 3 million outpatient visits. And it's costly in that 2013 direct medical costs for chronic constipation range from $1,900 to $7,500 per patient. And in 2011, the national costs for ER visits exceeded $1.6 billion. Now, the next slide shows something about the quality of life. We're using here the short form, which is a generic measure of functioning. And what you can see is that a lower score would indicate more impairment. So the green and orange represent two populations. One was self-report of constipation, and that pretty much matched the Rome 2 criteria. And the black line would be the normal population. And what you can see is a significant reduction in certain scales, all of them, but most notably vitality and feelings of general health. So this would indicate significant impairment in daily functioning.
Great, thanks, Doug. So in this slide, we're going to hear from several patients what it's like to live with their condition of CIC.
I don't think they understand how CIC impacts patients.
It hinders me from being myself, from living the way I want to live. I'm not the person I want to be.
I saw at least 10 physicians before I received that diagnosis.
I think sometimes it's just a catch-all diagnosis because doctors just don't know the causes.
Bill, is this representative of what you see among patients coming to you for constipation?
Very much so. What you really take away from these little clips is the level of frustration and the degree to which this affects people's day-to-day life and their ability to carry out their daily activities. I mean, I think the thing that really strikes me in taking care of thousands of constipation patients over the course of my career is that these patients suffer all the time. Literally, severe chronic constipation in particular is a 24/7 condition. So yeah, I think these are very typical comments from the patients that I see in clinic.
And I was surprised to see one patient up to 10 years before they made a diagnosis. It seems like diagnosing constipation would be a relatively simple thing. Is that, do you ever see that in your clinic, that there is a diagnosis despite seeing multiple doctors?
All the time. Every survey that's looked at this, not unlike irritable bowel syndrome, really finds that patients wander around with these symptoms for a long time. Whether that's related to delays in association with patients not reporting the symptoms to their physician or the physician not taking it seriously. A lot of times, one of the blessings and curses of constipation is that it's a symptom and a diagnosis. So a doctor can say, well, you have constipation. Well, that's not terribly helpful to a patient that's severely affected who's looking for answers in terms of trying to understand why they're constipated. And I also think that empiric approach provides an explanation for why none of the medical therapies work that particularly well, because we're targeting a specific mechanism, but we don't know whether that mechanism is the reason a person is constipated.
I think another thing that Bill alluded to, patients may not feel comfortable talking about it, and doctors, it's not necessarily on their radar screen to ask about it. So it is a message for the patients to be able to feel comfortable to mention this to their doctors as well.
Yeah, for sure. For sure. It's a really important point, is that I think, particularly for primary care doctors, where most of these patients really get their care, this is not going to necessarily be in the top 10 most important things that a primary care physician is going to be paying attention to or spending a lot of time on. They have so many different priorities that they're trying to juggle. I can only imagine how difficult it is to try to get to something like constipation.
Great. Well, let's move on and discuss how do we diagnose chronic idiopathic constipation. This slide shows the Rome 4 criteria for functional constipation. We use the terms interchangeably: chronic idiopathic constipation, chronic constipation, functional constipation. And we know that chronic constipation consists of symptoms of difficult, infrequent, or incomplete defecation. Those are the symptoms of it. They really vary from person to person. And because of this, the Rome criteria requires for the diagnosis to have only two more of these bowel-related symptoms that are listed on this slide. And these symptoms should be present for at least 25% of the defecations. And the symptoms I think you'll recognize as being very common are straining, lumpy or hard stools, sensations of incomplete evacuation, the sensation of anorectal obstruction or blockage, use of manual maneuvers to help with defecation, or having infrequent stools. And additionally, loose stools should be rarely present without the use of laxatives. And there shouldn't be sufficient criteria to make a diagnosis of IBS. And again, these symptoms must be present for at least 3 months, with the symptom onset for at least 6 months to really establish the chronicity of this, because we all experience intermittent constipation, which is extremely common, but this is really chronic constipation, long lasting. So although infrequent stools had been used to define constipation in the past, and some people still think of it as the only term, the only thing that's associated with constipation, the current definition of it incorporates other bowel-related symptoms, in part due to studies like this one. And this was a survey of individuals who reported being constipated. And they asked them what kind of bowel-related symptoms that they had. And you can see the most frequent symptoms were straining, hard stools, and incomplete evacuation. And infrequent stools, or less than 3 bowel movements per week, were present in less than 40% of patients who had chronic constipation or chronic idiopathic constipation. So it's not the only symptom. The other symptoms are actually more common.
You know, I think it means different things to different people. We always think, as you mentioned, about 3 bowel movements a week, but very often to patients, it's the amount of effort they have in having the bowel movement, or the feeling that it can't be passed. You know, diarrhea, everybody knows what diarrhea is. It's a loose stool. It could even be once a day. But constipation really depends on a variety of factors. So I think the message for the doctor is, when the patient says, I'm constipated, you can't take it at that. You need to ask them what they mean by the constipation.
That's a great point. And I think the other point to remember is that patients rarely come in saying, I'm just not having frequent bowel movements. They're coming in because they have other complaints. And these are bowel-related symptoms. We'll talk a little bit later about abdominal-related symptoms. Actually, in the next slide, I'm going to mention it, but that's also a frequent complaint of patients. This slide helps us understand the differentiation between functional constipation or chronic idiopathic constipation and IBS or IBS with constipation. And we often think of these as separate and discrete entities, but functional bowel disease disorders such as functional constipation and IBS with constipation really have significant overlap in both symptoms and pathophysiology, as shown on this slide. So we really want to think of these disorders as existing on a continuum rather than in isolation. And this figure illustrates this point, I think, very well. So a patient with IBS with constipation, that's shown in the upper right portion of this slide, will have more abdominal pain than a patient with functional constipation, which is shown in the upper left. And you can see the pain is one of the major differentiating factor. In contrast, the abdominal symptoms, which are shown in the middle, the predominant ones being bloating and distension, but abdominal discomfort would fall here too, may fall here as well, are similarly reported by both functional constipation and IBS with constipation. So Doug, do you want to walk us through the digital exam?
Sure. And before I do that, I want to mention about a study we did a few years ago of over 650 physicians, both gastroenterologists, primary care doctors. And what we found is that doctors are not doing the rectal exam. It seems to be related to that the older doctors and the gastroenterologists tend to do it more, but the younger doctors and primary care don't. And I think that's because they're not properly trained. Just today, I saw a patient referred to me for GI problems, and she had been to 3 doctors, including 2 gastroenterologists, and hadn't had a rectal exam. So I think it's important to remember this is part of the physical. It doesn't cost more, and there's a lot you can learn. In this case, we're giving you it by 3 positions. The first If you look at the rectum there, you'll see that at the bottom, you have the external and internal sphincter. So the first position is to just check the anal tone, which is based on the anal sphincters. Then you put your finger further in, and you'll see that you'll be reaching the puborectalis or the levator muscle. And if you put your finger in and you ask them to squeeze, what will happen is that you'll feel at the front of your finger the muscle pushing in. The third part of the exam is what we call expulsion, or asking them to simulate defecation. And what happens is the perineum descends, and it's not shown as well there, but the anorectal angle straightens. And by straightening, it allows for easier defecation. So the muscle, the puborectalis being taut like that, is maintaining continence, and it's supposed to relax with defecation. And when it doesn't relax, we have a problem that we call pelvic floor dyssynergia, which we'll hear about.
And Doug, this is all taking place in the left lateral position, correct?
That's correct. And you're seeing the pubis is to the right. So the person's in the left lateral.
And so the other thing that I do in my exams is I when I'm particularly showing the fellows, like I'll put my hand on the ischial tuberosities and say, and have the patient bear down and just show the fellows that the perineum should descend, but it shouldn't really pass the ischial tuberosities. It shouldn't go beyond 4 centimeters or so. So I think that's a helpful marker. Sometimes you see excessive peritoneal descent. And Bill, I want to get you involved with this. Bill, tell us about guaiacs. So we do rectals all the time. Should we guaiac our patients when we're doing a rectal? What's your feeling on that?
No, my feeling is you shouldn't, because here's the thing, is that the fecal occult blood test was never developed as a test to be done during digital rectal examination. Remember that all the studies that have utilized FOBT as a means to screen for colon cancer is testing done on spontaneously passed stool. One concern that you might have is that if it's at all a traumatic digital rectal examination, you could induce a false positive FOBT. So in general, the test has never been designed to be done during digital rectal examination, nor is it validated as a mechanism or as a means of identifying occult blood during a digital rectal examination. So I never do a fecal occult blood test as part of a digital rectal examination.
Great, thank you. Let's move on. So let's talk a little bit about pelvic floor dyssynergia, or as Doug explained to us how it's done if someone's not able to relax the pelvic floor appropriately. So Bill, do you want to just walk us through this condition?
Yeah, and this is a very important thing for all providers, primary care physicians, and certainly gastroenterologists to be aware of. And this is a condition where you're unable to coordinate the series of events that are necessary to allow normal passage of stool from the rectum. So realize that this condition is more common in women, but that doesn't mean it doesn't occur in men. Dyssynergic defecation absolutely occurs in men. The reason why we tend to focus on women is because constipation is so much more common in women. Actually, if you look at the proportion of constipated individuals with dyssynergic defecation, there's no difference between men and women. It's just that there's so many more women with constipation. That's why it dominates the proportion of people that are diagnosed with this condition. It's also, it can be identified by digital rectal examination. And Doug and Tony did a wonderful job talking about the findings that could identify dyssynergic defecation when you're doing your digital rectal examination. Another tip for listeners is to make sure that in the hand that isn't inserted into the anus and rectum, that you place that over the abdominal wall. That can allow you to feel whether a person is able to tense their abdominal wall musculature when they're simulating defecation. Because remember that so-called dyssynergic defecation can either occur related to the inability to relax the puborectalis or anal sphincter, or the inability to be able to increase intra-abdominal pressure through contraction of the abdominal wall musculature. So a problem with propulsion as opposed to a problem with relaxation that allows emptying of stool from the rectum. The patients with evacuation disorders can also be identified through the use of a balloon expulsion test. And then finally, a high resolution anorectal manometry can be helpful as well as another means by which to identify this important condition.
So,
Did
Bill,
oh, go ahead.
Bill, I'm curious if I interrupt you. I'm curious, what percentage of patients do you think, both in a specialty and a primary care or, or secondary GI practice, would have dyssynergia?
Yeah, I think a good way to frame this question, Tony, is what patients should a provider be most concerned might have an evacuation disorder like dyssynergia? And the answer is patients who are refractory to typical laxative therapy or fiber. So think about this. Remember that studies show that individuals with dyssynergic defecation don't get better with laxative therapy. Therefore, populations of constipated patients that don't respond to laxative therapy are enriched for an evacuation disorder. Okay, so think about testing for this condition in individuals who don't respond to empiric laxative therapy. It turns out the digital rectal examination is a very valuable screening tool. You can see from this slide, the sensitivity and specificity are actually quite good for identifying patients with dyssynergic defecation when done by an individual who's experienced in identifying those characteristics of the digital rectal examination that Doug nicely outlined.
I think it could be as much as 30%. I don't know if any series, maybe either of the other two, when patients come in with constipation. But there's something from the symptoms too. Bill Whitehead, who is at UNC where I was, published a study where he looked at when you ask patients about straining being a very important part of dyssynergic defecation. You strain because you haven't relaxed. Most people will strain if they have hard stools and constipation, because the vector is such that the small balls, it's hard to get it out. But if you say to them, do you strain to initiate a stool or all throughout the stool as it's coming out, he found significantly more patients had dyssynergia when they're straining during the defecation process, because for most people, once you get it started, it's okay.
It's an interesting point. And I'll make one other point, because we've actually studied this too. And actually in a study of almost 1,000 patients who had manometrically proven dyssynergic defecation by ARM and balloon expulsion testing, the most predictive symptom for dyssynergic defecation was a sensation of incomplete evacuation after a bowel movement. Unfortunately, and this is true for straining as well, probably almost 90% of dyssynergic defecation patients endorse that symptom. But if you ask regular constipated patients who are negative for dyssynergia by ARM and BET, it's still around 70 to 80%. So it is statistically significantly different, but it's clinically meaningless, unfortunately.
That's great. Now, I mean, we're emphasizing dyssynergic defecation, which may be new to some practitioners that don't see a lot of patients with GI problems. But the reason for that is that the treatment's so different, right? I mean, we're going to we'll talk a little later about biofeedback, but there are other things that you may want to do for your patients, including making sure that they elevate the feet. When they're defecating, they can get a footstool or a squatty potty or something like that, which can sometimes be helpful. And of course, as Bill emphasized, teaching them how to contract the abdominal wall, which is often done by biofeedback, physical therapists, but something that you can start with your patients.
Yeah, one pro tip for the gastroenterologists in the audience who are doing anorectal manometry, we now actually do a balloon expulsion test without squatty potty. And then if it's abnormal, redo the balloon expulsion test with squatty potty. And what we found is that around 20% of individuals with an abnormal balloon expulsion test will correct by using a step stool to elevate their knees above their waistline. And so, on my report now, I write, patient had an abnormal balloon expulsion test, which was corrected through the use of squatty potty. And and it's a very practical tip. It takes all of 60 seconds more time to do it. And when you find that, you not only make a diagnosis, you also identify a therapy.
Thank you, Bill. You taught me something great here. I'll put that in my practice. Well, let's move on in the interest of time, and we'll have plenty of time for questions and answers and more discussion later. Bill, do we need to do a colonoscopy on all of our patients? So you're going to talk to us about what a test we should do. You want to answer that question first? Is a colonoscopy required?
Well, we definitely don't need to do a colonoscopy in everybody. Age-appropriate colorectal cancer screening is really the order of the day for patients with chronic constipation, and that's really important, and there's lots of different ways to skin that cat, but we definitely don't need to do a colonoscopy in every patient with constipation. A young person with intermittent constipation does not need a colonoscopy. In fact, the pretest probability of colorectal cancer or any other important organic disease is no different in that individual than it would be in an otherwise healthy, non-constipated person. Tests that you might want to think about in patients who have laxative refractory constipation outside of the balloon expulsion test and anorectal manometry that we've already talked about include testing for colon transit. Okay, and these include studies that utilize radio-opaque markers and basically assessing how quickly or how slowly those move through the colon. Something called Smart Pill, which is a wireless motility pH capsule that gives you a snapshot of transit through the stomach, small bowel, and colon. And then, of course, there's also scintigraphy. We really reserve all of these tests for circumstances where a person has not responded to usual medical therapy. And we always start with the pelvic floor before we assess colon transit. Remember that colon transit time in a patient with a significant pelvic floor problem will oftentimes have an abnormal transit test, and you can't determine whether or not the abnormal transit test is from slow colon transit or from the evacuation disorder. So always start with the pelvic floor before you assess colon transit.
Hey, Bill, what would you be recommending for primary care? These are some sophisticated tests.
I wouldn't recommend these for primary care. What I would say is that in the primary care setting, in my opinion, being familiar with the dietary and lifestyle remedies that might be helpful, the over-the-counter laxatives, and the prescription options. And every primary care physician is going to need to determine the level of comfort that they have with the various prescription options. But once those things don't work, it's time to refer to a gastroenterologist. And when the gastroenterologist sees these patients, if they've failed a number of different treatments, it's time to think about physiological testing.
Well, it's a good segue. Let's move on and talk about the treatment options for patients with chronic idiopathic constipation. We know, if you walk down into any drugstore, there's usually an aisle or a half an aisle dedicated to laxatives. So we have a lot to learn today, and then we'll go into the prescription therapies. First, we have another question for our audience, but let's just review the patient that Doug presented earlier. KM is a 45-year-old teacher referred to you by her primary care physician. She has infrequent stools. She has abdominal symptoms, including bloating, as well as lots of bowel symptoms, hard stools, small stools, straining, incomplete evacuation. And she's had an evaluation of a colonoscopy, anorectal, and manometry and dephrecography, and she has evidence of dyssynergia. So here's the question for our audience. What primary treatment approach would you recommend for KM? Okay. Let's hear from our patients again. What do patients with CIC say about the way they're being treated?
The only way I manage my CIC is through diet, fiber.
I've taken a myriad of medications, from over-the-counter medications, from stool softeners and fiber, laxatives, and many multiple prescription medications.
Doug, does this accurately represent the ends of the spectrum that you see in your clinic?
Well, it could be the ends of the spectrum of patients who are getting benefit, as on the left, from those who are not. My question here is, maybe we need to look at other treatments if they're not responding very well. So I think that patients do use a lot of over-the-counter medications, but a point may be reached, like the woman on the right, where they need to go further. But if certainly if the woman on the left is doing well, then that's fine.
Great. All right, let's jump right into the treatment options. And Bill, can you walk us through lifestyle and OTC approaches for our CIC?
Sure. And I think it's important to say that it's always reasonable to start with these things, but I couldn't agree with Doug more that there are many patients, moderately or severely affected patients, that will not respond to these different measures. I think that one of the things that leads to the greatest degree of frustration on the part of patients is when they're saying they have moderate or severe constipation, and yet the main recommendations that they continue to receive, dietary modification, hydration, and exercise. Those are the three big pillars of dietary and lifestyle modification for patients with chronic constipation. A couple things to say coming out of the chute. First, for hydration, realize that for the most part, constipated patients don't drink less water during the course of the day compared to non-constipated patients. Now, that said, an NHANES study that looked at this did identify that individuals in the lowest quartile of fluid consumption per day were more likely to be constipated. So in those circumstances where you identify that a person is not drinking very much in the way of fluid per day, so at least 2 to 3 liters of fluid per day, then it's worthwhile providing counseling and instructing them to drink enough fluid. But if a person is drinking enough fluid each day, it won't be helpful to tell them to drink more fluid. Similarly, you could say the same thing for fiber. So getting people to a total daily consumption of around 25 to 30 grams of fiber per day. By the way, that's not 25 to 30 grams of supplemental fiber. That's 25 to 30 grams of total dietary and supplemental fiber per day. Once you get a patient to that level, if they're not responding, they're not going to respond if you give them more fiber. Okay, so just be aware of that. Soluble fiber appears to offer greater benefit than insoluble fiber, but it probably to a large extent depends on the type of soluble and insoluble fiber. So soluble fibers like psyllium or ispagula husk are evidence-based treatments for chronic constipation. We simply don't have enough data on many other forms of fiber to say whether they do or don't work. I can tell you this, which I think is quite interesting, and that is that particle size may make a difference. So for example, if you give rough bran, studies suggest that does provide a laxative benefit. On the other hand, if you give finely ground bran, it actually is constipating. So there may be more to it than simply the fiber content. That may have to do with particle size and the impact of the actual substance within the visceral lumen of the GI tract. Finally, there's a lot of discussion about exercise, and there is data to suggest that individuals that engage in regular, vigorous exercise move their bowels more regularly than individuals who are sedentary. So again, if a person is sedentary, getting them to exercise makes a lot of sense. If a person is active, it won't be helpful to ask them to be more active. Hopefully that makes sense. This slide gives you an idea of the wide array of different over-the-counter remedies that are available for patients with constipation. Tony mentioned that, a half aisle. That's true. I mean, if you walk down the drug aisle for constipation in any drugstore, there are literally rows of different types of over-the-counter laxatives. What are the evidence-based over-the-counter laxatives? Well, those would be in those black boxes that you see: polyethylene glycol, lactulose, which are 2 evidence-based osmotic laxatives, and bisacodyl and sodium picosulfate, both evaluated in methodologically rigorous randomized controlled trials, and they're both stimulant laxatives. Now, there are a lot of other osmotic laxatives, magnesium salts in particular, which surprisingly have not been tested in randomized controlled trials. Now, that doesn't mean they don't work. That just means that we don't know whether they work or not, and if they work, how well they work. For stimulants, there are a variety of other ones. Senna, everybody I think is very familiar with. In fact, you can find evidence that the ancient Egyptians used senna as a treatment for chronic constipation. But also other natural treatments, including cascara, rhubarb, and aloe, are other stimulant laxatives, which can be found in just common dietary elements.
Bill, are patients satisfied with these treatments? I mean, how well do they actually work?
Yeah, it's an interesting question. There have been a couple of survey studies now, one of which is depicted on this slide, which would suggest that while almost half of the patients are satisfied, that tells you that a significant minority are not satisfied. This study suggested that 28% were not satisfied. There are other studies that suggest up to 40% are not satisfied. So again, a substantial minority of patients with chronic constipation don't get better with the usual things that we do before we start talking about prescription medications.
Great. Well, in the interest of time, let's move on to the prescription medications. And in this slide, it overviews the two major classes of the prescription medications that we have. On the left are the secretagogues, and on the right, the prokinetic agents. The secretagogues work by increasing fluid into the lumen of the GI tract. This increase in fluid causes peristalsis and movement through the GI tract, including the small bowel, where a lot of the fluid actually occurs. Now, most of this fluid is reabsorbed before the stool is expelled in the colon. So actually the difference in water content is usually relatively small. There are currently 4 secretagogues available by prescription. All of them are available by prescription, actually. One of them is lubiprostone, and it's shown, you can see on the upper left area, works on the CLC2 receptor. Two of them two of these, like linaclotide and plecanatide, work on the guanylate cyclase C receptor, which opens up the CFTR channel. These 3 all cause an increase in chloride to occur in the GI tract, and then water and sodium follow. The 4th drug is called tenapanor, which you may not be familiar with. It was recently approved. It's not yet available on the market, but was recently FDA approved. It works differently. It works on the sodium hydrogen exchange 3 receptor. So it blocks the reabsorption of sodium, and in turn water and chloride follow. Prokinetics, at least for the lower GI tract, because there are some different prokinetics in the upper GI tract, in the lower GI tract, they work by stimulating the 5-HT4 receptor. This receptor induces peristalsis in the GI tract, and that in turn propels stool through the colon. It actually propels movement throughout the entire GI tract, because that's its major mechanism. There are actually two 5-HT4 agonists on the market, tegaserod, which was recently reapproved, and prucalopride, which is available for constipation. Now, tegaserod, as I mentioned, was reapproved. It's only available for women under the age of 65 who have IBS with constipation. And therefore, we're not going to be discussing this medication further than during tonight's program, but we will be discussing the other 5-HT4, prucalopride, further in the upcoming slides. Doug, do you want to walk us through the data with lubiprostone?
Sure. Lubiprostone is a prostaglandin analog, and it was the first of the secretagogues to be developed. So it's a non-absorbable GI-targeted bicyclic fatty acid. And as I said, it activates the CLC2 channel, causing obligatory water excretion. The dosing, there actually are 2 doses, an 8 microgram twice a day for IBS, and a 24 microgram twice a day for CIC. The side effects to consider would be diarrhea, headache, and particularly for this drug, nausea, because it is a prostaglandin analog. And so this can occur in a substantial proportion. If it occurs, you can try to take it with meals. And this is some data published, about 12 years ago, that shows the improvement in stool consistency, straining, and constipation. And what you can see starting with stool consistency is you went from moderate to severe or hard, that is hard to loose, normal to hard stool, to loose to normal stool, and straining went from moderate to mild to moderate. And then the constipation severity was also significantly reduced, which is a derivative of the others.
Thank you, Doug. Now let's talk about linaclotide. As I mentioned, it's one of the two GCC agonists that stimulate fluid secretion. In an animal model, the second messenger, cyclic GMP, also seemed to cause reduction in the firing of nociceptive receptor neurons. So that may be its presumed mechanism of how it may improve pain. The dosing for chronic idiopathic constipation is 145 micrograms once a day. The 72 microgram dosing is also available that may be used on, depending on the individual presentation. Although in clinical trials, side effects such as diarrhea seem to be similar between 72 and 145. But in my practice, it seems to be, I do get some benefit, a reduction in diarrhea when that does occur. Because diarrhea does occur in some patients, and the other side effect that's reported is abdominal pain. Now, let me walk you through some of the clinical trial results. On the left-hand side is the two phase 3 trials that were done with linaclotide. The primary endpoint is an improvement or an increase of 3 complete spontaneous bowel movements per week, as well as an increase in 1 per week for 9 out of the 12 weeks. But the real hurdle for meeting this endpoint is more than 3 per week, because most patients start somewhere between 0 and 1 complete spontaneous bowel movement. The average is about 0.5 when they come into the baseline. So that's really the big hurdle for it. And as you can see, it is a big hurdle because only about 20% of patients in one of the studies receiving linaclotide 145 micrograms met this endpoint, but it was significantly different. And you can see the very low placebo response rate, suggesting how difficult this endpoint is to meet, again, for the complete spontaneous bowel movements. And on the right-hand side is another study that was done with linaclotide. And this study was patients with chronic idiopathic constipation who had bloating as a predominant symptom. They had to have severe bloating at baseline. And this shows you the results of the improvement in bloating that occurred with linaclotide during the 12 weeks of the study. Let's move on to the next GCC. Bill, do you want to walk us through plecanatide?
Plecanatide is a uroguanylin analog, and like linaclotide, is an agonist at the guanylate cyclase C receptor. So it increases chloride secretion with passive movement of sodium and water, which obviously could be beneficial to patients with chronic constipation. This drug is approved at 1 dose, 3 micrograms or 3 milligrams, daily in adults with chronic idiopathic constipation or IBS-C. And the main side effect is diarrhea, reported in around 5% of patients in the randomized controlled trials. On this next slide, you see data from the 2 phase 3 randomized controlled trials, which evaluated plecanatide versus placebo in patients with chronic idiopathic constipation, and both showing statistically significant increases in the proportion of patients who were complete spontaneous bowel movement responders. So they had an increase of at least 1 complete spontaneous bowel movement per week with treatment compared to baseline. And you can see that the therapeutic gain was around 10% in each of the trials, with around 20 to 21% of patients treated with plecanatide responding by the definition that I outlined for you.
Great, thanks, Bill. So in the interest of time, let's move on to discuss prucalopride. As I've mentioned, it's a 5-HT4 agonist, so it's a prokinetic that works throughout the GI tract. Some recent data showing that it may improve gastric emptying, but in the colon, it increases decreases colon transit time and improves colonic motility. It doesn't interact with other serotonergic receptors in the blood vessels. We'll talk a little bit more about that in a minute. It is available at 2 doses, 1 milligram and 2 milligram, but 2 milligrams is a starting dose. 1 milligram is available for patients with renal insufficiency. And of course, you still can lower the dose, which I do sometimes in my practice, depending on the patient need. The most common side effect seen with prucalopride is headaches, and diarrhea also occurs, but a relatively small percentage, under 2% in clinical trials, had to withdraw due to the diarrhea. So the next slide shows you some of a meta-analysis of 6 phase 3 trials, because the thing to know about prucalopride was that it was initially studied in the United States and then studied in Europe, and it actually was available in Europe for, I'm going to guess, around 10 years before it came to the United States. So it had has undergone extensive studies, in this case, 6 phase 3 trials, a meta-analysis with a similar endpoint, not quite as rigorous as I just mentioned. This is the average over the 12 weeks. So you do see a higher response rate and a higher placebo response rate as well, but it shows you, in effect, that there's a significant improvement over placebo. Now, there were some concerns regarding cardiovascular safety about the class of drugs, the 5-HT4 agonist. I've already mentioned tegaserod, and some of you may be familiar with cisapride. These were drugs that were withdrawn from the market. In the case of tegaserod, it was reintroduced onto the market in a limited population of low cardiovascular risk. Importantly, though, with prucalopride, it does not interact with the cardiac hERG potassium channels, as did cisapride, and it doesn't interact with other serotonergic receptors in the blood vessels, and therefore is not associated with an increase in major adverse cardiovascular events. And this has been well studied. Let's move on and talk about, we've already discussed a little bit about dyssynergia and biofeedback, but Doug, you want to walk us through more details on this?
Sure. And before we do that, I want to ask both of you, because this has been my clinical experience, that sometimes, because there are different modes of actions between the secretagogues and the prokinetic agents, do you ever combine the two?
Oh, yeah, all the time. So we, I tend to see more like Bill. I would see a very refractory patient. So we're combining secretagogues with prokinetics. I'm not combining secretagogues with secretagogues,
Right.
and I wouldn't combine. I try not to combine osmotics with a secretagogue as well. I usually will go to a stimulant laxative or a prokinetic agent.
And I think that the prucalopride may have a leg up or an advantage when you have more right-sided colonic transit problems, where you get fecal retention and overflow diarrhea, because it is a prokinetic agent as opposed to just putting more fluid in. So I find that's a good time to use both as well.
Yeah. And we've gone over this quickly, but just to re-emphasize, so just for the audience, how we think about the drugs. Now, we talked about a lot of prescription drugs. It's important to remember that that many of them are also available for IBS with constipation. The dosing may be a little bit different in some, but not all. Plecanatide's the same dose. Linaclotide is actually a higher dose for IBS-C, and for lubiprostone, it's a lower dose for IBS-C. Prucalopride, however, has not been studied in IBS-C, so it's only available in CIC.
But tegaserod has been.
And tegaserod has been studied in both, but it's only available in IBS-C. Thank you.
Right.
Like,
So,
you want to anorectal manometry, biofeedback?
Sure. This is actually a very effective treatment by clinical experience in some clinical studies. Chiaroni and Whitehead. This paper was by Camilleri. But about 70% of patients with dyssynergia can respond to biofeedback. There are some methodological issues, and further research may be required, but I would definitely weigh in on the benefit of applying that if someone's dyssynergic. The centers will usually do a combination of patient education, training on how to relax the puborectalis muscle with abdominal pushing, and then practicing simulated defecation by use of the balloon expulsion tests. In my own practice, I will, by doing the rectal exam, can train some patients by teaching them to relax and push as well. But for more specific treatment, you would go with the biofeedback device. And in addition to that, depending on what other features are going on, the neuromodulators can be very helpful for the treatment of pain. And pain is a component of the patients with CIC. It acts by noradrenergic and serotonergic pathways. And those neurotransmitters have relevance in terms of constipation and diarrhea. So if you're having constipation, an SSRI, which is more serotonergic, would be more likely to help transit. May not help pain as much, but it would be helpful for the constipation. Conversely, tricyclics have more noradrenergic activity, and that's a constipating agent. It can also help for pain. So you can start to select out based on which agent you're using. CBT can be helpful because patients, as we saw from this woman, didn't want to go out, was very frustrated. She had a lot of maladaptive or negative thinking and anxiety because she felt so miserable and somewhat pessimistic. Well, CBT helps patients to think differently in response to their symptoms. And then is also evidence that gut-directed hypnotherapy can not only improve subjective responses, but can actually improve colonic motility and pain.
Great, thanks, Doug. Let's go back to our patient, and this slide reviews the symptoms. And I'd like to hear from both of you, Doug and Bill, what would you do next on this patient? How would you approach her?
Well, I guess I'll start. I feel that she's moved to a point having one bowel movement a week, and it's not on this slide, but on the second slide, it showed that she had already tried fiber. I think she's beyond the over-the-counter products and probably needs to go with either a secretagogue or a prokinetic medication. But she also had dysenergic defecation. And as Bill very well pointed out, you can slow transit by having dysenergic defecation. And in fact, there's some evidence that treating dysenergic defecation can actually improve colonic transit. So I would do this concurrently. I would treat her with a pharmaceutical agent and also set her up for anorectal biofeedback treatment. I think the proctogram confirmed that the rectocele that was found was of no clinical significance, because sometimes a rectocele can cause problems by retention of stool, feeling of incomplete evacuations, and sometimes that has to be treated separately, but not in this case.
And Bill, when would you start a secretagogue versus a prokinetic? And are there any specific secretagogues you think are better than the others? Tell us your approach.
So this goes back a little bit to the previous discussion. It very much is dealer's choice in the sense that there are no comparative effectiveness trials to really guide whether one treatment is better than another. So the way I make a decision for an individual patient that I'm taking care of in the clinic has a lot to do with what the patient has previously tried. So all of us are in tertiary referral centers. So the patients that we see have all tried things before. So that has a huge influence on what I choose. And then the other thing, which you hate to say, but it's just the reality of life in 2020, is that insurance coverage to a large extent dictates what you will prescribe. So those are probably the two main variables that I think about. I'd love to tell you that I know what you're looking for, which is that, well, if a person had this symptom, I would choose this drug. Unfortunately, I don't personally believe that symptoms have great enough specificity to allow us to make the right treatment choice for an individual patient. So, in fact, there is a way to go more precision more of a precision medicine approach in terms of choosing therapy, but that's through doing the physiologic evaluation that I said to you a moment ago. And here we already know that this patient has dysenergic defecation. To me, the first order of business is getting that corrected. Okay. And that means physical therapy and biofeedback training. I agree with starting a concurrent laxative regimen, but I'll tell you one thing that I would definitely tell this patient is that it's very possible that if the constipation is from dyssynergia, and my suspicion is once a week is probably not all from dyssynergia, but if the constipation is largely from dyssynergia, that the laxatives will work considerably better once you finish pelvic floor retraining.
And Bill, do you really push aside the stimulant laxatives? I mean, there's some data with bisacodyl showing that it is very potent, maybe the most effective at stimulating increasing bowel movements. So would you try bisacodyl or send out this patient? But if no, if not, why not? And how long would you continue them? Are they safe long term?
So we really don't know. I'm not personally a believer that using stimulant laxatives leads to colonic inertia or neurogenic colon. There's a lot of discussion about that, and I think that if you had 10 thought leaders in a room, you'd get 10 different answers on this. But bottom line is, I've looked at this literature, and there is not good literature to support the development of damage to the enteric nervous system or the interstitial cells of Cajal with chronic use of laxative therapy. I would actually argue that the studies that have made that argument may well be observing the natural history of chronic constipation over time, not the effects of stimulant laxatives. So I have no trouble with using stimulant laxatives, and many of my patients are using stimulant laxatives. I try not to use them every day in large doses, but I absolutely will use them as a rescue medication when patients who are taking a prescription medication, for example, are feeling more constipated. I have no hesitation about telling that patient to using an intermittent stimulant laxative like bisacodyl or Senna.
And I would echo that. I tend to use bisacodyl as rescue if they're on a regimen like this and they haven't responded for 3 days or so, I might have them take that as rescue and try to get them back on track.
Thank you. And what I was alluding to is, a clinical trial, the only clinical trial of bisacodyl that showed significant improvement in bowel movements, spontaneous and complete spontaneous bowel movement. But in fact, there were many patients that had severe diarrhea, abdominal pain. 50% had abdominal pain as a side effect. 25% withdrew from the study. And as I like to tell my patients, if I give you enough of a laxative, whether it be polyethylene glycol, Senna, that it'll make you go, but you'll maybe miserable when going. So, and to that regard, for many patients, a drug like prucalopride, which may not be as effective in the clinical trials, that's because the dosing may be lower, is less likely to cause pain and diarrhea in your patients. So it's kind of a balance between having significant efficacy. And I agree that bisacodyl for my practice is better as a rescue. And once they get above 2 to 3 tablets, they tend to have a lot of cramps, a lot of discomfort. But for a more daily approach, I think the patients tend to be more comfortable, at least in my practice, with something like prucalopride. But I use Senna very regularly in my practice.
Yeah, I was just going to say, I think, the stimulant story, it's not something that you really want to do every day. And I clearly, above a certain threshold, it just isn't effective. So, but that said, there are specific circumstances where patients are really severely constipated, and you're trying to do everything you can to avoid having to do a colectomy, in which it can be helpful.
Would you recommend medications for adolescents or children? Do you want to just speak on them, whether they're?
Well, I mean, I think the big thing is to remember that linaclotide is not FDA approved in children. So you probably would not want to use linaclotide. And actually, I don't know if Tony, maybe this better than I do. I don't know if there are actual pediatric trials for a lot of the medications. I know there are some for PEG, for example, but there aren't a lot of pediatric trials for the prescription medications in the constipation space.
Right. And just emphasize that the GCCs are contraindicated.
Right.
Under the age of 6, just because of increased mortality in animals, young animals. But in the interest of time, this is a great discussion. I appreciate it. But in the interest of time, let's move on. I want to go back to the question that were presented earlier. And now that you've heard the discussion, why don't you go ahead and tell us what you think your primary approach would be to KM. All right, pre and the post. There was a switch to more prescription laxative. Doug, I think you convinced a lot of people to use that, and an increase in anal rectal biofeedback. Do you guys, any comments, guys, or you?
That's a tough question, because I think we're also talking about 2 treatments also at the same time. And I think one of the things there's no one-stop treatment. Very often we use combinations. We talked about prucalopride with a secretagogue. We talked about biofeedback with one of the pharmaceutical agents. Sometimes we back up treatments with PEG solution if we're not getting adequate response. So I would agree that this is reasonable because the top two are in line with what we've been discussing. I would have liked to have seen the question of using both.
Great. Let's move on in the interest of time. This is the third learning objective. And just for those of you that have been to programs like this before, you know, we usually end the program at about this time. But really this time we have a few more learning objectives, which I think are really unique for these type of programs. And I think you'll enjoy them a lot. First, so we're going to be talking about multidisciplinary collaboration and care coordination in our patients. So let's first by jumping in and hearing what patients say with CIC say about collaborative care.
I really only have my gastroenterologist that's helping me, and I do not feel that is enough. I actually believe that a dietitian would be very helpful because they could help you find what foods to eat and what not to eat and what might help. Perhaps a psychologist so that you could deal with the inability to do things that can cause anxiety.
Great. Let's just jump into the next slide. And Bill, you've been doing work on collaborative care. You're really one of the leaders in this area, in many areas of the GI. You want to just tell us what you've learned through the years of this topic?
Sure. And we really are entering a new age because as we've talked about during this program and really as you're reading about in the medical literature, diet-based treatments, behavioral therapies like cognitive behavioral therapy and self-directed hypnosis, as well as medical therapies, as we've spoken about in great detail today, are all evidence-based treatment options for patients with chronic constipation. Now, why should we think about these things as siloed alternatives, as mutually exclusive treatment options for patients with chronic constipation? Does it make sense to think about a more holistic, a more integrated, a more collaborative approach that incorporates all of these different treatment options to different degrees in individuals with chronic constipation? If you think about like the way that the care model has evolved, and we'll go to this next slide now. When I was a fellow in the 1990s, we were very much in this red box, the traditional care model, which focused on the gastroenterologist and almost always led to a patient being prescribed an over-the-counter or prescription medication. Over time, as we gained evidence supporting the use of diet-based treatments, behavioral therapies, as well as medical therapies, we started to see the value of a multidisciplinary approach. Now, there's a big difference between a patient seeing a dietitian, a behavioral therapist, and a gastroenterologist versus integrated care where these different healthcare providers work collaboratively to come up with an integrated care plan for an individual with chronic constipation in this particular example. It turns out that there's now very compelling evidence from a randomized controlled trial that was just published in Lancet Gastroenterology and Hepatology just within the past 6 weeks. Actually, this paper was published. 188 patients from Australia, Melbourne, that were randomized to either usual GI care or integrated GI care. And you can see the definitions here. For usual care, it was a gastroenterologist. And by the way, this gastroenterologist could get a dietitian or a behavioral psychologist referral, but those individuals were not part of his or her team and were not part of the same institution. So the best case scenario was that the patient saw the gastroenterologist and these other healthcare providers. And then there was integrated care, which was care provided by a team-based group of providers consisting of dietitians, hypnotherapists, psychiatrists, as well as gastroenterologists and biofeedback physical therapists. And you can see the results really speak for themselves. That integrated care model yielded 84% improved outcomes in these patients with functional GI disorders, compared to 57% in the usual care arm. By the way, we just completed a survey that we'll be presenting at the ACG meeting, which will report that around 40% of US gastroenterologists don't have access to a GI dietitian. So this usual care in this study was not usual care for many gastroenterology or patients with gut conditions in the United States, where we're not even to the point where we are in that multidisciplinary care phase. So just realize that we're a long ways from this idealized approach. But in 2020, I will make the argument to you that integrated care, particularly for patients who are severely affected, is now the standard of care. It's no longer the exception. It should be the rule. And hopefully, digital models incorporating telehealth, for example, will allow for the possibility of developing and scaling integrated care models in the United States.
Hey, so Bill, what could a doctor out in practice do to get a dietitian or a psychologist?
Yeah, so there are a couple different ways that you can approach this. First thing is that the Rome Foundation actually has a gastropsychology working group, and so on the Rome website there is actually a listing of different GI psychologists who are working within the United States. The second thing is the International Foundation of GI Disorders, the IFFGD, also has on their website a listing of GI dietitians all across the United States. So those two sources can be a very valuable resource for gastroenterologists working in the trenches. And then finally, by way of disclosure, I'm on the board of a group called GI OnDemand, which is actually a telehealth platform that's being co-developed with the American College of Gastroenterology. And GI OnDemand will offer a virtual care platform. So not only gastroenterologists, but also fully trained GI dietitians and behavioral psychologists who will be available for telehealth services. So lots of interesting things are in development right now. And by the way, it's not just GI OnDemand. There are other platforms that are developing very similar models. So this is coming. And as we scale this, every gastroenterologist in the United States will have the ability to access integrated care if they choose to practice in that way.
I think COVID is really making telehealth a lot easier these days. And I think it's going to move us in a new direction for the future.
Yeah, I agree.
Bill, do you think a pharmacist should be included in integrative care? Is that?
Yes, in fact, there are some practices, for example, some of the Kaiser practices, which were way ahead of the curve in regards to the development of these types of models, do include a pharmacist. So yeah, absolutely. I think there's so many interesting ways to think about this. You know, another thing that we've been speaking about a lot is also geneticists. You know, if you think about like the genetics of HNPCC, of diseases like porphyria, Wilson's disease, a whole range of different diseases, having access to genetic counseling will also be very important going forward.
Okay, in the interest of time, let's move on. This is our last section, which Doug's going to lead us on the patient-provider relationship. Doug is a world's expert and a wonderful teacher on this. So Doug, why don't you take this section away?
Sure. If you're interested in hearing more about this, this slide is coming from a paper that came out from clinical gastroenterology and hepatology just 2 months ago. Well, 3 months ago, 2 months ago in June. It was co-written by Johanna Ruddy, who's a patient and patient advocate. And so working together, we kind of tried to address the issue of the patient-provider relationship in terms of the healthcare system and in terms of patient perceptions and needs. And I just want to highlight these points that we don't have much time to spend with patients anymore. 45 minutes in the 1970s to 12 minutes last year. The Marcus Welby art of medicine is disappearing. which I still value as being extremely important in establishing a relationship, engagement, nonverbal behavior, proxemics, how you sit with the patient. All of this can help patients feel more comfortable and provide more meaningful information and feel trusting with the doctor. And we're being kind of hammered by technology, which has great value in identifying structural and biological causes. But anyone who's been a patient or any doctor who's treated patients know that the correlation between structural findings and physical symptoms are about 0.3. I had one resident say, why talk with and examine the patient when I can get a CT? So this poor correlation means that we have to use technology as guidance for understanding disease, but illness or the patient's experience of ill health has to be done through the medical interview and the patient-provider relationship. And this is even made more difficult because 60% of the time is spent on documenting and certification through EMR, accrediting agencies, as shown here, certification and the like. And this is unfortunately leading to increasingly dissatisfied patients and dissatisfied providers. Providers don't feel comfortable with the way patients are responding because they just don't have the time. The Rome Foundation has been looking to try to teach clinicians this. And if you're interested, go to the website and we can get you engaged. So if we were to state what are the key points of the provider-patient relationship, you got to state the diagnosis. There's been studies to show, particularly for patients with functional GI disorders, the doctors don't give them a definitive diagnosis, much like they would for Crohn's disease or ulcerative colitis, because it's not structurally based. It's based on criteria, and doctors don't always feel comfortable. And then patients come away and say to their next doctor, I never had a diagnosis. So you have to be firm about it. You need to set up mutually agreed upon goals and expectations. This is chronic illness. You need to make sure the patient understands what is going on and responds to the information you give them. So it's a dialogue. It's not just showing them a video or giving them a handout. And you encourage collaboration. So if you're making recommendations, don't just say one drug. Give them this drug. Drug A has this effect, these side effects. Drug B has this effect, these side effects. What would you like to use? And in doing so, if later, 3 months down the line, they're not doing better, it's not all on you to find another drug. You both work on solutions together. And of course, in the end, you have to like your patients, positive regard and empathy, and engage with them. And that usually leads to mutual satisfaction.
So thank both of you. I think today's discussion was incredibly useful and it covered some areas where we may need to make some changes. I won't summarize today's goals, but they're listed here for you. Rather, we have a number of excellent questions and only a limited amount of time. So let me just jump straight into some of the questions. And the first one, Doug, is for you. It's regarding the role of telemedicine, especially in the COVID era. How has that affected the doctor-patient relationship? Or do we not know that yet?
We're learning some things. There was an interesting paper that just came out from China that showed that wearing of, and this is probably from China because they wear it all the time, most often more than the US. It's a new phenomenon in the US, but this was at a medical center that showed that the communication of empathy is reduced when you wear a face mask. So you have to make special efforts to try to communicate that empathy. Another phenomenon that's going on, I know speaking for myself, I really need to see the patient face to face. And while telemedicine is valuable because you can see the patient, you don't see body language, there's a tendency to get a little bit discomfort in staring at people as opposed to being there one-on-one, because even eye contact, when you're looking at someone on a screen or a group of people, you're staring at them, and that's generally not as comfortable as when you're person to person and you look away sometimes and look back at them. So I think there's a lot to learn. I think where it's here to, I think it's going to be here to stay. I think things are going to change, but it doesn't diminish in any way the need to be effective in communication skills, and that can be verbally as well.
Great. Well, thank you. Bill, there's a question on genetic counseling, just to expand upon that a little bit. How do you guys use it, and do you in your practice now?
Well, increasingly there are genetic, as you know, as we gain more and more knowledge about the human genome, we're making diagnoses that matter in terms of genetics and maybe even in terms of the choice of treatment. So genetic counseling, I think, is really, in terms of colon cancer, for example, has really become a very standard part of our practice. Microsatellite instability, evidence of HNPCC, obviously FAP, and then there are a wide range of other types of disorders in which genetics plays a role. And people have questions about what risk, for example, their kids are at, whether or not their kids need to be tested. What does the future hold in terms of expectations for the natural history of disease? And genetic counseling can provide solutions and reassurance and information on a lot of these topics for patients.
Great. There are several questions regarding the medications, both OTC and prescription, regarding the safety of long-term use. So again, OTC, stimulant laxatives, as well as prescription. Do you want to comment on?
Sure. I mean, that's a big concern. I literally go through this every day that I'm in clinic with patients. Patients have huge concerns about, quote, becoming addicted or dependent to laxative therapy. And this is how so first of all, there's no evidence that I'm aware of that suggests that that's true. In fact, I would argue to you that the opposite is true. I would argue to you that just as we understand heart failure to be a condition, for example, if you think about how does hypertension lead to heart failure over time? Well, the strain related to uncontrolled hypertension leads to progressive dilation and loss of function of cardiac muscle. I would argue to you that the same may well be true in the setting of chronic constipation. Progressive and recurrent episodes of fecal loading may very well lead to chronic damage and loss of function of colonic muscle. And I would argue to you that one of the reasons we know that is because these patients oftentimes over many years will develop progressive dilation of the colon. And just related to understanding of Starling forces, we know that when you stretch a muscle fiber repeatedly over time and you stretch it enough, it will lose function. So I would actually argue to you that it's very important to adequately treat chronic constipation and prevent the recurrent episodes of recurrent fecal loading, stretching and damaging the colon over time, and then leading to long-term consequences. So to me, the long-term consequences of leaving severe constipation untreated far outweigh any risks associated with the use of long-term laxative therapy.
Great, thanks. Doug, there was a question about differentiating IBS-C from chronic idiopathic constipation. We didn't go into IBS-C in great detail. I was wondering if you could just say a few words about the differences and how to do it.
Yeah, we had a slide to that effect. If you recall, you were looking at, on the ordinate scale, you had stool consistency going from loose to hard, that is from constipation, diarrhea to constipation, and on the right you had pain. And basically you have a continuum. And one of the things about Rome 4 was the message that these are not etched in stone, these conditions. They move around. Some of our data show that in 1 year, 74% of patients changed their categorization when we followed them, about 200 patients. So there it is, good. So if you look to the right, as you move toward pain, you're dealing more with IBS. And as you move up or down, you're dealing with constipation or diarrhea. So on the left side, you may not have pain, you have functional diarrhea and CIC or functional constipation. That's not to say that this is a categorical difference. I think there's considerable overlap, but we tend to look at this more dimensionally, as I said, than categorically, So when you're having more significant pain, you're going to look at different dosages of your secretagogues. You're going to be looking at whether you're going to add a neuromodulator. Whereas if you're just having no pain, you're functioning, your treatment is going to work specifically on the constipation or the diarrhea.
Great, thank you. There was a question, we have time for a couple more. There was a question differentiating stimulants from prokinetics, the mechanism of action. The stimulants cause spasm of the colon. So they have multiple effects, but one of the effects is spasm of the colon. It's not a peristaltic contraction, which is what you'd see in a prokinetic agent. That's a 5-HT4 agonist. So spasm also causes increased secretions of stimulant laxatives. There's a question about surgery in patients with chronic idiopathic constipation. We didn't get into the truly refractory patients. These are quite rare. Even at our center, it was less than 5 or 6 patients a year undergo surgery. We really try to avoid them. There are other avenues that we explore. Sacostomies occasionally are being done, and some institutions are doing that, and that just allows for the flushing of the colon. Most of the adults in the pediatric world is commonly used. Some places in the world are using sacral nerve stimulation, although the data is not very good with it. And there are other therapies, or electrical stimulations, vibrating capsules, things like that that are not commonly used. So we didn't get into great detail. We tried to keep it practical for the practicing physician. And I think as we have just 2 minutes left, I'll take one last question about the combination of treatments in our refractory patients. I think someone said, could you revisit that? I don't know, Bill, if you have any additional comments.
Yeah, I think you summarized it really nicely, Tony, which is that logic would dictate that you should use medication, you should combine medications with different mechanisms of action. So using an osmotic with a prokinetic, for example, or a stimulant. As opposed to combining drugs that both have osmotic properties. Now, that said, I have some patients that came in on combined osmotics and prosecretories, and they're doing great. But if you ask me, my personal choice is to use drugs that have different and potentially additive MOAs.
Great. Well, thank you everyone for participating. Our time's just about up. Doug and Bill, it's been a great discussion. I've learned a lot. I hope everybody else has as well. Thank you to the audience for the great questions and for participating today. We hope that you'll be able to use the strategies we've shared to diagnose, treat, and communicate with your CIC patients. If any of your colleagues missed today's program, it'll be archived in the Gastroenterology Hub at www.cmeoutfitters.com/gastro hub. Thank you very much for everyone.